Welcome everyone, and thank you for tuning into our webinar today titled Genetic Testing for Infertility. My name is Gina, Londre, and I'm one of our lab genetic counselors at Prevention Genetics. Please note that we will not be taking audio questions. If you would like to submit a question, please submit it either through the Q&A or chat dialog box on the right-hand side of your screen. Please feel free to submit questions at any time, and all questions will be answered during the Q&A portion of our program after the presentation. I will start by reviewing a bit about our company and then go into some background information about infertility. From there, I will turn it over to Dr. Fang, who will go deeper into the genetics of infertility. By the end of the webinar, we hope that you will know the incidence and major causes of infertility, understand the major genetic contributions to infertility, as well as the benefits and limitations of genetic testing for infertility. So before we delve into the topic of infertility, I want to first give you some information about Prevention Genetics. We were founded in 2004 by our president and CEO, Dr. James Weber, who had a vision of disease prevention through genetic testing, which is our continued vision today. We only accept test requests for clinical testing ordered by healthcare providers. And we do, however, also offer DNA banking, which is our one direct-to-consumer product that offers long-term secure storage of an individual's DNA. We offer the largest test menu in the United States of high-value clinical germline genetic testing with disorders ranging from prenatal to adult onset and affecting all different organ systems. To give you a flavor of our varying test offerings, this image is from our website showing our different disease area specialties, and all of our PhD geneticists have different specialties in these areas. Our mission is to provide high-quality clinical DNA testing to anyone in need at an affordable price. We are a comprehensive, high-quality laboratory that is CLIA, CAP, and ISO accredited. We pride ourselves on our exceptional customer service as part of that. And as I briefly mentioned before, each of our PhD-level geneticists has specialty in a given disease area. We take great care in interpretation and curation of sequence variants identified and have a thorough review process. This includes manual interpretation and review by 4 highly trained, experienced individuals to ensure we get the test right. With that, I'll now dive into our main focus of this webinar, which is genetic testing for infertility. So infertility is defined as the inability to conceive or have a recognized clinical pregnancy within 12 months of sexual intercourse with no contraceptive measures taken. For couples who are 35 years and older, this time frame is actually shortened to 6 months. Reports in the literature vary, but overall prevalence of infertility ranges anywhere from 6% up to 20%. It is difficult to pinpoint one reason for the variation in prevalence, but it is likely due to factors such as delayed childbearing, varying habits that affect fertility, changes in sexual behavior, and many others. Both males and females can be affected and are equally affected, and in some instances, a combination of both female-related and male-related issues result in inability to conceive. The reason for a couple's infertility, of course, again varies, and literature-reported numbers vary as well. However, female-related indications, male-related indications, and both female-male-related issues, as well as unexplained infertility, all account for about 1/3 of cases each. For female-related indications, irregular ovulation, including oligomenorrhea and amenorrhea, and pelvic issues account for the majority. For male-related indications, abnormal semen analysis, which includes oligospermia and azoospermia, accounts for the majority of male-related indications. Many couples have a combination of factors or no clear etiology for their infertility. When couples seek help for infertility, there are many pieces that come into play in the workup and then ultimately the management of the infertility. Most couples will begin with an infertility evaluation or consult, which takes into account maternal history and paternal histories. So these include menstrual history and OB history in the woman, and then medical histories, family histories, as well as lifestyle factors in both the man and the woman. Physical exams may also occur to assess any obvious physical clues for infertility. Certain lab testing will also happen to assess reasons for infertility. This can include semen analysis to assess number, mobility, and motility of semen, ovulation tracking, genetic screening, and infectious disease screening. There's also testing and additional evaluation performed to look at ovarian reserve and tubal patency in women. When considering options for treatment, a first stop in the process is well-timed intercourse. Depending on what lab testing and workup reveals, and if well-timed intercourse is not proving successful, other courses of action may be considered. Some of these include use of oral medications such as Clomid that affect ovulation, or injectable medications such as FSH to stimulate the ovaries. Couples might consider intrauterine insemination, which is often called artificial insemination. Others may also try assisted reproductive technologies like in vitro fertilization, also known as IVF, with or without intracytoplasmic sperm injection, where the female eggs are removed and inseminated with the partner's semen with eventual transfer of the embryo back to the woman's uterus. Although there are many approaches depending on the workup and what ultimately happens, approximately 75% of couples who seek help for infertility will eventually conceive. With that, I'll turn it over to Dr. Fang. She's our geneticist here, and she joined Prevention Genetics in January of 2016 as a clinical cytogeneticist. Her portfolio focuses on reproductive disorders and infertility. She received her PhD in genetics from Antigen University in China. So with that, I'll turn it over to her.
Thanks, Gina, for the great introduction. So in the next 20 to 30 minutes, I'm going to talk about the major genetic contributions to infertility and also explain the benefits and the limitations of genetic testing for infertility. So firstly, I'm going to introduce how sexual development and reproductive function occur by the action of hypothalamic pituitary gonadal axis. So this HPG axis is a hormone system in humans. Normally, the hypothalamus segregates a hormone called gonadotropin releasing hormone, GnRH, which are transported to the pituitary gland. There, the releasing hormone, GnRH, acts on the anterior pituitary gland, causing it to produce and segregate two gonadotropins called luteinizing hormone, LH, and follicle-stimulating hormone, FSH, which have a direct action on the ovaries in women and testes in men. LH and FSH are essential for stimulating the development of secondary sexual characteristics seen at puberty, and they also play important roles in maintaining the normal sexual function of both men and women, including maintaining the correct levels of sex hormones, testosterone in men, and estrogen and progesterone in women. So in the past decade, much has been learned about the genetic etiology of reproductive dysfunction in humans. Reproductive disorders in humans can somewhat be divided into hypogonadal dysfunction and eugonadal dysfunction. In patients with hypogonadal dysfunction, they usually manifest low level of sex hormones compared to eugonadal states. Hypogonadal states represent a more severe perturbation in reproductive function. However, the molecular basis of hypogonadism has been better understood, and increasing numbers of disorders now are known to be caused by genetic abnormalities. In contrast, the genetic basis of most eugonadal disorders, such as polycystic ovary syndrome, is largely unknown. So in this presentation, I will primarily focus on the genetic basis of hypogonadal disorders. It has been estimated that genetic abnormalities can account for approximately 15 to 30% of cases with infertility. So these genetic abnormalities include chromosomal anomalies, which can be either numerical or structural abnormalities, such as most common chromosome abnormalities, Klinefelter syndrome 47XXY, or Turner syndrome 45X. Another known genetic abnormality in infertility is single gene alterations, such as mutations in CFTR or AR gene. So the HPG axis in the human is regulated through a variety of genes. Some studies have shown that mutations in a lot of genes expressed in the HPG axis can cause pubertal and reproductive deficiencies in humans. So among the reproductive disorders in humans, hypogonadotrophic hypogonadism is the one that the underlying genetic cause has been well studied. Mutations of genes expressed in the hypothalamic or pituitary generally result in hypogonadotrophic hypogonadism, which is a condition of absent or deficient puberty owing to low-level gonadotropin. Decreased gonadotropin separation results in reduced reproduction of sex hormones. So the patient with hypogonadotrophic hypogonadism often present impaired sexual development. Its prevalence is about 1 in 4,000 to 1 in 10,000 in male, and it happens much more often in males than in females. So the hypogonadotrophic hypogonadism is associated with a normal sense of smell, which is normostic hypogonadotrophic hypogonadism in approximately 40% of affected individuals, and an impaired sense of smell, which is common syndrome, in approximately 60%. So with the advent of improved molecular biology techniques, the genetic basis of an increasing number of hypogonadotrophic hypogonadism has been identified. Mutations in at least 35 genes can cause hypogonadotrophic hypogonadism in about 40 to 50% of patients. So here shows the traditional algorithm of diagnosis and genetic test of hypogonadotrophic hypogonadism. The algorithm explains the flow from the clinical diagnosis to the genetic diagnosis. So I will not go through this algorithm in detail. I just want to show you as an alternative to the sequential molecular genetic testing described here, a multi-gene panel can be used for simultaneous analysis of some or all the genes associated with hypogonadotrophic hypogonadism. And this multi-gene panel should be the first step when the proband has no clearly affected family members or no associated phenotypic features. Treatment for common syndrome or other forms of hypogonadotrophic hypogonadism can be divided into hormone replacement therapy and fertility treatment. Hormone replacement therapy is to ensure the level of circulating hormone at the normal physiology level for the age of patient. Fertility treatment is to administrate the gonadotropin in order to stimulate the production and the release of eggs and sperm. So there is a very good successful rate for achieving fertility for patients with hypogonadotrophic hypogonadism based on experts' reporting up to a 7% of successful rate. So the genetic testing will greatly facilitate the early diagnosis of hypogonadotrophic hypogonadism and help start with the treatment as soon as possible. In the next few slides, I will be focusing on men infertility and its genetic cause. We know a fertile male has a functional reproductive tract and can produce enough healthy, functional, and mobile sperm. Approximately 7% of men from the general population are confronted with fertility problems. So in addition to physical exam, one of the important tests to diagnose and define the severity of the male factor is semen analysis. This analysis will provide sperm density, total number, and motility. Infertile male patients often show oligospermia with low sperm count than normal, or azoospermia with no sperm in semen. Approximately 1% of all men are afflicted with azoospermia, and it is also seen in about 10 to 15% of infertile men. So what is the genetic cause for the semen defect in male? We know a very frequent cause is chromosomal aberration. Chromosome abnormality occurs in 0.4% of general population. Severely impaired sperm production is associated with a significantly higher frequency of chromosome aberration. So the chromosome aberrations can be found in up to 5 to 10% of men with semen defects. This patient usually presents mild to severe oligospermia, and it can be detected by whole chromosome microarray or traditional chromosome analysis. More than half of the chromosome anomalies in infertile men are numerical sex chromosome abnormalities, such as Klinefelter syndrome 47XXY, which is most common chromosome abnormality in male infertility, and sex chromosome translocations and structure aberrations are also found in infertile men. In addition to sex chromosome abnormalities, autosomal translocations, inversions, and other structural abnormalities can account for about a quarter of chromosome anomalies in infertile men. As I mentioned earlier, Mendelian disorders are also known to cause male infertility. So firstly, let's look at the Y-linked disorder, YQ microdeletion. Many studies have proven that YQ microdeletions are the most common cause of male infertility. It has been seen in about 5 to 15% of male with semen defects. So the clinical indication for Y chromosome deletion tests are based on sperm count and include non-obstructive azoospermia or severe oligospermia. The American Urological Association has recommended YQ microdeletion screening in all infertile patients with less than 5 million sperm per milliliter. So male with Y chromosome deletion usually have no obvious symptoms, although physical examination may reveal small testes. Y chromosome deletion inherited in a Y-linked manner. Cases of Y chromosome microdeletions usually occur de novo, and due to the infertile phenotype, they are typically not transmitted. In cases where assisted reproductive technology is used to achieve pregnancy, male offspring have the same deletion as their father, with a higher risk of male infertility. So the clinically relevant deletions occur on the long arm of the Y chromosome and remove partially or completely one or more azoospermia factor region, AZF region. So AZFA deletions are very rare and usually produce the severe phenotype of fertility cell only syndrome. AZFB and AZFB plus C deletions are uncommon and usually result in azoospermia. AZFC deletions are relatively common and result in variable infertility phenotypes, ranging from azoospermia to severe oligospermia. Testing for deletions involves investigating for the presence or absence of markers located within non-polymorphic regions of AZFA, AZFB, and AZFC regions. Y chromosome deletions are detected by multiplex PCR amplification. So here is an example of multiplex PCR result. So in parallel to the patient DNA samples, positive and negative controls must be run in each multiplex. As we can see here, the lane 3 is a negative control we used, which is a normal female DNA. Lane 4 is a positive control we used, which is a DNA sample from a man with normal spermatogenesis. Lane 5 and 6 are patients with AZF region deletion, and lane 5 shows a patient with AZFB deletion, and lane 6 present patient with AZFC deletion. Over 99% of AZF microdeletion can be detected by this assay. The treatment is usually the testicular sperm extraction followed by intracytoplasmic sperm injection. However, this treatment is not feasible for AZFA or AZFB or AZFB plus C deletion, since there is no sperm in semen. In patients with AZFC deletion, there is a 15% of success rate to achieve pregnancy. So the correct diagnosis of the genetic cause of infertility is very important for the further treatment of patients. Another Mendelian disorder in male infertility is X-linked disorders. As I talked about earlier, hypogonadotrophic hypogonadism have been identified. Many genes have been identified in male infertility. Another X-linked Mendelian disorder is Antigen sensitivity syndrome. Antigen receptor gene is located on XQ11 to 12. The function studies have suggested that the AR signaling plays an important role in meiosis 1 during spermatogenesis. So lack of AR may lead to spermatogenic arrest. The complete ARG mutations are associated with a complete antigen insensitivity syndrome with a female phenotype, which include the primary amenorrhea, normal breast development, minimal axillary and pubic hair, blind vaginal punch. While incomplete forms of ARG mutations were detected more frequently in infertile men. Other autosomal genetic anomalies have also been included as tests for assessment of infertile men. We know that some infertile men have complex genetic syndrome in which fertility is a minor manifestation. For example, hypogonadotrophic hypogonadism, Bardet-Biedl syndrome, hemochromatosis. Also, infertility can be observed as a major manifestation. For example, congenital bilateral absence of the vas deferens. We know it's a minor and incomplete form of cystic fibrosis. It is estimated to occur in 1 in 1,000 to 1 in 10,000 and maybe encountered in 1 to 2% of infertile males. Mutations in genes for FSH and LH also have been observed in men with infertility as a major manifestation. So in order to include all the Mendelian disorders in male infertility, in prevention genetics, we developed a male infertility NGS panel, including 80 genes. So the genes and genomic regulation involved in male sexual determination, sex hormone synthesis and action, testicular development, male genital tract development, spermatogenesis, as well as central cause of hypogonadism have all been included in this panel. So here is our comprehensive male infertility testing in prevention genetics. We offer the Y chromosome microdeletion test, which can detect all the most 5 common microdeletions on Y chromosome. We offer the chromosomal microarray, which can detect the chromosome abnormalities as well as copy number errors. And also we just developed our male infertility NGS panel, which includes 83 genes. These genes are associated with hypogonadism, spermatogenic failure, or as well as syndromic or non-syndromic male infertility. Here is a recommended flow chart for genetic tests in male infertility. We know for most infertile patients, they perform semen analysis. If the sperm concentration is less than 5 milli per milliliter, we recommend to do a Y chromosome analysis to detect all the microdeletion. If it's negative, the whole chromosome microarray or cytogenetic analysis is recommended to detect all the chromosome abnormalities. If the chromosome analysis is normal, the patient can go ahead to perform the male infertility NGS panel to detect all the Mendelian disorders in male infertility. So next, I'm going to focus on the genetic cause in female infertility. So the female patients with hypogonadotrophic hypogonadism often manifest syndromes of estrogen deficiency, such as absent breast development or amenorrhea. It is usually caused by gene mutation expressed in hypothalamus or pituitary. As we know, mutations in at least 35 genes can cause hypogonadotrophic hypogonadism in about half of the patients. In patients with hypergonadotrophic hypogonadism, they usually present elevated FSH and LH, as well as defects in ovary. The genetic cause of hypergonadotrophic hypogonadism include chromosome abnormalities, FMR1 expansion, and single gene mutation. We know a very frequent cause in male infertility is chromosome aberrations as well. More than half of the chromosome anomalies in infertile women are numerical sex chromosome abnormalities, such as 45X Turner syndrome, 46XY gonadal dysgenesis, 47XXX syndrome. Sex chromosome translocations and structural aberrations are also found in infertile women. In addition to sex chromosome abnormalities, autosomal translocations, inversions, and other structural abnormalities can account for a quarter of chromosome anomalies in infertile women. So in addition to chromosome abnormalities, Mendelian disorders have been found in infertile female patients as well. Probably the most known cause is CGG repeat expansion in FMR1 gene. We know approximately 20% of women who have a FMR1 pre-mutation develop premature ovarian failure. Other autosomal genetic anomalies have also been included in infertile women. We know that some infertile women have complex genetic syndrome, such as galactosemia, hypogonadotrophic hypogonadism, hemochromatosis. Also, infertility can be observed as a major manifestation. For example, mutations in genes for FSH, LH, or GNRH have been observed in women with infertility as major manifestations. And another important Mendelian disorder is premature ovarian failure. So premature ovarian failure is genetically and phenotypically heterogeneous disorder characterized by primary amenorrhea or loss of menstrual function before the age of 40. The patient often present elevated levels of FSH and decreased level of estrogen. This patient shows varying and unpredictable ovarian function, and the most severe form is ovarian dysgenesis, where the pituitary development is severely affected. So the genetic cause of premature ovarian failure includes chromosome abnormalities, such as Turner syndrome, as well as a single gene alteration. As we know, at least 14 genes have been identified in patients with premature ovarian failure. And also, I mentioned earlier, the FMR1 gene, CGG repeat extension, which is the most common and clinically important cause for premature ovarian failure. So In prevention genetics, we also developed a female infertility NGS panel, which include 83 genes. So genes are the genomic regulations involved in female sexual determination, sex hormone synthesis and action, ovarian development and function, and general cause of hypogonadism are all included in this panel. So in prevention genetics, we offered this comprehensive female infertility panel. We offered the chromosome microarray to detect all the chromosome abnormality as well as copy number variants in female patients with infertility. We just released this female infertility NGS panel, which could detect about 50% of female patients with hypogonadotrophic hypogonadism and 15% of patients with premature ovarian failure. And also we have the FMR1 triplicate repeat testing to detect the premature mutation of the FMR1 gene. So here is a recommended workflow chart for the genetic test in female infertility. Here we mainly focused on infertile female patients with hypogonadal dysfunction. So in female patients with hypogonadal dysfunction, we recommend to do a whole chromosome microarray or chromosome analysis to detect the chromosome aberrations. If the chromosomes are normal, we then recommend to do the female infertility NGS panel to detect all the Mendelian Disorders related to female infertility.
Well, I think we can all appreciate that there is value in understanding the underlying etiology of a couple's infertility. Genetic testing can especially allow for more informed care of the patient. So specifically, it allows for more informed genetic counseling. So this allows the ability to conceive. The ability to conceive can be more accurately addressed, along with discussions for potential recurrence risks for the couple's children. Additionally, where applicable, it can also allow for prenatal diagnosis. And then, of course, in having a genetic diagnosis, there's value in genetic testing to know if treatment options are available for a couple, as well as management for the individual and or couple long term. So I think Dr. Schutz gave some great examples. For example, hypogonadotropic hypogonadism is treatable and can be treated with gonadotropins. And then also, it can influence exactly what type of assisted reproductive technology a couple might use, whether it's truly using an ART option such as IVF, or just relying on other different types of medications that might allow for a couple to conceive. And then, of course, in an individual, there's diagnostic and prognostic value in managing that individual. And with that, we want to thank you for joining us today. We just wanted to end by sharing our test information for the varying options we offer at our lab. With that, we are happy to proceed to our question and answer portion of the webinar. Just a reminder, if you would like to submit a question, please submit it through either the Q&A or chat dialog box on the right-hand side of your screen. With that, we'll go ahead with our first question. Our first question is, what is the coverage like on the next-gen sequencing panels? Are there any holes?
So the average coverage for our NGS panel is 200, and we also provide the single backfill for all the low coverage regions, as well as for genes with homology issues. So basically, it's the coverage is very great in our NGS panel.
So another one is related to the coverage. So you noted what the average coverage is. It looks like, what's the minimum coverage?
So the minimum coverage is 20x, and we also cover the intron with a coverage of 10x.
If there's certain cases we have questions about, is there the ability to reach out and ask questions about your test offerings? So I can answer that. So yeah, so if you did have any questions about our test offerings and testing specifically for male or female infertility and what panels we offer, you can certainly contact us at the contact information listed on the screen here. So both Dr. Zhu and my contact information is here, but also you can reach out to us specifically through our client services line, our GC line, or email address, and we're happy to answer any questions you might have about a specific case. Okay, another question. What has your experience been like with insurance coverage? I'll go ahead and take that one. So specifically for this panel, we're not sure, and I think, you know, it's kind of a generic answer, and I know it's not always the best one, but it really just depends on a couple's insurance plan and if they even have benefits for genetic testing, generally speaking. We're happy to help with investigating insurance benefits, so we can do pre-verification as well as pre-authorization if needed, and we can do that on the front end even before a sample is sent in. So if you're specifically wondering for a given patient, we can certainly look into that and help you address that. All right, now we'll take this last question here. Can we split the disorders of sex development panel up based on phenotype? Gonadal dysgenesis versus androgen action/synthesis problems, take out the infertility genes. So I guess I'll let Dr. Xu answer this as well too if she wants to, but generally speaking, we're pretty flexible in our test offering. So if there was something more specific you wanted for a patient and, you know, maybe some genes in the panel weren't what you were hoping for or needing for a given patient, we can be flexible and certainly address those questions as they come up.
And also we have a large NGS panel, which includes all the genes involved in disorders of sex development and infertility. So this panel has 96 genes. So if you add, so this is a large panel. You can
order, utilize,
yeah.
Mm-hmm. All right, and with that, I think we're going to conclude our program. If you have any additional questions, of course, please feel free to reach out to us, and thanks again for joining us.